Good evening. From Rhode Island Public Radio and the Rhode Island Public Health Institute, it's a special hour on one of the greatest public health challenges of our time. We're talking about an infectious disease that affects millions of Americans, thousands of Rhode Islanders among them. Hepatitis C has been called the silent killer because most people don't know they have it. It attacks the liver slowly, quietly over decades, and left untreated, it can lead to cirrhosis, liver cancer, and even death. But there's hope. Brand new drugs have just hit the market that can cure hepatitis C. The trouble is, they are so expensive, nobody knows how we're going to pay for them all. Our guests tonight have some answers. They're going to help us dive into this dilemma and explore some solutions. So I'm your host, Kristen Gourlay. We are broadcasting in front of a live audience here on the campus of Brown University. Stay with us. So hepatitis C isn't always easy to talk about, right? It's partly because of how you get exposed to this disease. There's a lot of stigma surrounding this. And you get exposed mainly from injecting drugs and sharing needles or drug paraphernalia. And Hep C is incredibly infectious. It takes contact with only a microscopic amount of blood to get exposed. And here in Rhode Island and throughout many parts of the nation, we've got really something of a perfect storm brewing, I think. More and more young people are getting hooked on prescription painkillers, opioids, and then turning to heroin, injecting heroin, and that's putting them at risk of hepatitis C. So that happens to be part of Jonathan Goyer's story, but there's so much more to his story than that, of course, and I'd like to welcome him here tonight. Welcome, Jonathan.
Thank you.
So, Jonathan, let's just start off with a big one. You are in recovery from addiction.
I am.
19 months, is it?
19 months.
Congratulations.
Yes.
It's awesome. That is not easy. So let's just jump right into it. You also have been diagnosed with hepatitis C.
I have,
So
yes.
Tell us, how did you get hepatitis C? What happened?
Well, at the age of, as a young teenager, I began using drugs intranasally, and that just quickly progressed into IV drug use. By the age of 18, I was an IV drug user, and I was sharing needles with people. And if you don't mind, I'll tell you the 1 minute version of the story.
Yes.
of how I was diagnosed with hepatitis C. I had a using buddy that I was using with, and we scored some heroin, and we only had one needle. And I was so sick, going through physical withdrawals, the physical opiate withdrawal, that knowing full well that he had hepatitis C, it didn't matter to me. I needed that shot of heroin, to the point where I knew the risk involved, and it just didn't matter to me.
Mm-hmm. You're really brave to be here tonight. I just want to say that and to share your story.
That's not everybody's story. Yeah.
I have to say, though, it strikes me, so many people, I talked to a lot of people who have chronic hepatitis C in my reporting on this series I did called At the Crossroads, and so many people said to me, I knew the person I was sharing a needle with had hepatitis C, but I was so sick it didn't matter. And for people who haven't been addicted, aren't familiar with addiction, it's probably a little hard to understand, but it gets to that point where you're so desperate, you'll do anything.
If you're living under a bridge shooting heroin, you probably don't care that much about your health.
Fair enough. So I'm curious about the reaction of your family and friends to your diagnosis. Have you faced any stigma, any reactions you want to share?
I haven't really. My family's been very supportive of me and supportive of my recovery, understanding that that's going to happen first before any other medical issue
Right.
is addressed.
So no stigma. That's
not from friends or family.
Yeah, but
generally, yeah, I suppose you could say that. Not everybody's too, very fond of IV drug using. People on the street living under bridges and prostituting themselves and whatever else they're doing to make money.
Mm-hmm, mm-hmm, mm-hmm. So you are getting the medical care you need now, which is great. But you haven't had your hepatitis C treated yet. Can you talk about why that is?
So, having gotten to recovery, and by the way, I just want to mention, linking somebody to care, and I'm a hepatitis C test counselor nowadays also.
Pretty amazing.
Linking somebody to care, the biggest barrier in doing that is if there's substance abuse.
Right.
A substance user, nothing can be addressed until that is addressed first, in my experience. Once I got into recovery and stabilized in my recovery, I decided to inquire about, hey, I should probably get this treated. But most importantly, getting into recovery, I stopped the risky behavior, the risky behaviors that I was engaging in that put me at risk in the first place. And once I stabilized in recovery, I sought treatment. Now, having been somebody that was unemployed living on the streets, I didn't exactly have Blue Cross insurance. So I signed up for Medicaid. And as I began to inquire about treatment, I noticed that there was a lot of testing that I had to do, blood work and biopsies and ultrasounds. But that's when I hit the barrier of, hey, there's these great new drugs, but your insurance won't cover them.
And we're going to talk about that in a little bit, those treatment options. But first, I just also want to mention, you've come so far since those moments, under a bridge, sharing needles. You are literally the face, or one of the faces of a new campaign, a media campaign in the state of Rhode Island, promoting recovery. Addiction is a disease, recovery is possible,
Yes.
and which is incredible, and that's really brave. And I just wonder if you could tell us a little bit more about your life now.
Oh boy, it's much more entertaining if you want the past version of my story, no? So basically, I found recovery through other friends that were in recovery, and they almost just addressed it as a sort of a harm reduction issue of just being loving and empathetic towards me and compassionate, never shutting the door on me, and and just being there and loving me until I was willing to love myself. And that's the thing that you see with a lot of these people. If you're doing at-risk behaviors, you clearly don't love yourself. So I think it's really up to us as a community to love them until they can.
And you mentioned you're also now a hepatitis C testing counselor. Can you
Yes.
talk a little bit about your work?
So I work for a nonprofit organization called Project Weber, funded by Department of Health. It is a nonprofit that is funded to test and link to care a targeted population of at-risk men on the streets of Providence. And I'll just tell you briefly, last year I've tested 150 people. 14 of those were HIV positive. Almost 50 were Hep C positive. And these are people that are primarily living on the streets, and probably about 60% of them are IV drug users.
Wow. So we'll get back to some of that in a little bit. I'd like to introduce the person sitting next to you, who happens to be, we've talked about this, it's okay to say, your doctor as well,
Okay.
Dr. Thomas Seepy. Welcome, Dr. Seepy.
Thank you.
So you're a liver specialist here in Providence, you're a gastroenterologist, and you treat patients, some of whom have hepatitis C. And I'm just wondering if you could tell us, are you seeing more patients like Jonathan today than you were, I don't know, say five years ago or so?
I think we're seeing a large number of more patients now with the amazing revolution in antiviral therapy in the last year. We have a long history and a long experience with patients like Jonathan who have histories with substance abuse and have really turned their lives around and have made it into therapy and have been cured by antiviral therapy. Right now, the amount of work that's presenting to our liver center is, quite frankly, overwhelming because the word is out. And if the word hasn't been out, hopefully it's going to be out further this evening.
The word that we have new treatments, we can cure
We
you.
have new treatments. Just very briefly, the history of antiviral therapy is really a long one and a disappointing one. 20 years ago, we were giving people interferon shots 3 times a week with about a 5% chance for cure. Now, treating people is really simple. The drug regimens that we have had developed at our center and are coming into clinical practice all have cure rates well over 95%. And more importantly, the side effect profile is essentially none. And, for those of us who've been treating really thousands of patients over a 25-year career, it's been an evolution, but we've had a lot of treatment delivered. We've cured many patients over the years, but the morbidity has been really staggering.
And when you say morbidity, you mean
Side
sickness,
effects.
side effects.
Side effects. Interferon therapy, the cornerstone of old treatment, very, very difficult to undertake. Ribavirin, its cousin, is soon to leave. Very problematic, very difficult. The newer treatments, just to give perspective, there are two that are now approved, but one that was approved in October called Harvoni. Our experience with it is about 70 in the trial space, and we have right now close to 70 people on Harvoni, and no one's having side effects. It's unbelievable. So it's a great time. It's what should be the most exciting time of my career. And I think as we're going to address for the remainder of the hour, there are many frustrations that are preventing us from really being able to share that with all of our patients.
You mentioned that patients are just coming out of the woodwork. They've heard about the cures available, the new treatments available, and they want to get treatment. What kinds of what manifestations of this disease are you seeing in your clinic? For people who aren't as familiar with what hepatitis C can do to a body, tell us about what you're seeing.
Sure. Well, probably 40% of my practice is a referral base for cirrhotic patients. Our center right now is diagnosing 3 to 4 patients with liver cancer from hepatitis C per month in Providence. And while we've had major improvements in the therapy of hepatoma in the last decade, it's still very problematic. It's still cancer, and it's very costly. So I think we're going to be talking more about costs. I think every dime that we're going to be deploying using these drugs is worth it. Because if the average liver transplant costs $650,000, and the average first attempt at hepatoma therapy is almost $250,000, $90,000 doesn't seem so problematic anymore.
And that's the average cost between the
Let's
two
just call it 90
newest
for
drugs.
now. It's higher in some instances.
It's a lot.
It's a little less in some instances. It's a lot of money, but this is a curative therapy. This isn't a suppressive therapy. It's a curative therapy.
So these drugs are hugely expensive, as you mentioned. We will be
Yes.
talking about this a little bit more, but I just want to say those numbers one more time so it sinks in. $84,000 is the price of Sovaldi, which is one of the newest drugs out there. And you have to take that, I think, in combination with other drugs sometimes, right? And then Harvoni is another of the newest drugs, and that's $94,000 per course. But although it's one pill a day, right? So that's a huge
Correct.
improvement on what you had before. But, understandably, insurers, payers are being pretty careful about who they approve to take these drugs. What's it been like for you and your staff to try to get people on these medications?
That's a 4-hour teleconference in and of itself. But the reality of it is it's incredible. So my Hep C nurse, who really manages most of our prior approvals, spends anywhere from 15 to 20 hours a week now trying to get prior authorizations.
A prior authorization, by the way, is paperwork you have to fill out before you can get a drug from an insurance
Assuming
company.
that we can get a drug. So we have medications that might be on formulary. We have restrictions, and I think that's important to understand. Jonathan's story with his insurance in Rhode Island. Rhode Island's part of a Medicaid consortium that has restricted therapy for advanced patients, sicker patients, F3, F4. I support the Medicaid policy. I don't agree with it. All should be treated, but right now we have limited funds and we need to cure the sickest patients first. On the other hand, the conversations we've had in private are really, they're very profound. He has turned his life around. He wants to be cured. He has other aspirations that are best kept in private between us, and I can't treat him at this point. And it's frustrating. It's very frustrating for him, many others. We've had patients crying in the office, yelling at us, yelling at the director of Medicaid. It's been a very amazing 6 months of frustration.
Yeah. You're listening to Hepatitis C, Cost, Cure, and Challenge on Rhode Island Public Radio. We are broadcasting live from Brown University. I want to come back to you, Jonathan Goyer. You know, as you listen to Dr. CP talk about these treatments and the frustrations, you know, your thoughts.
Well, I just want to point out, too, that one treatment that is available is interferon. And it's been available for a while, but I just want to make it a point to tell everyone, if you got hepatitis C, you were probably an IV drug user, such as myself, and the side effects of interferon can be parallel to the side effects of drug withdrawal. So for somebody like me who's new in recovery, that's why I got out of the using drugs, because I didn't want to feel those sort of side effects anymore.
Yeah. That's something people don't think about, I think, is that, you know, just trying interferon is uncomfortable at the very least for people, but for someone who's new in recovery, it could feel like withdrawal symptoms and be a trigger, essentially, right?
Correct.
Okay. So insurers, we've just been talking about, are, you know, they're in a bind. You recognize, Dr. CP, that, you know, Medicaid can't afford to treat everybody right now, much as you'd like to, right? And yet, you know, Jonathan is waiting. You have other patients who are waiting. You mentioned they're crying in your office. I mean, this is heartbreaking. What are the human costs of waiting?
Well, the biggest cost would be if that patient decompensates or develops a liver cancer while we wait to get them on treatment.
Can you explain decompensate?
You had mentioned that earlier in the introduction. So two things happen as people get sicker from liver disease. They can develop liver cancer, which we've talked about, and then their liver can just give out and fail. And that would require a liver transplantation to maintain life. And unfortunately, where we live in the Northeast, most people die on a liver transplant list in New England, then get them because there aren't enough grafts. So the stakes are very high. There's also a concern that many practitioners have is this artificial F3, F4. You know, it's a continuum, and people can be F2, F3, and they're actually sicker than one would think.
And those are stages of cirrhosis or fibrosis.
These are stages of damage from the liver disease. And it's a very slippery slope to be so dogmatic to say we can only treat the very sickest. The one thing we haven't mentioned, too, is we're focusing on the sickest patients from a liver perspective. We also have many patients who have secondary manifestations from Hep C, a growing link to diabetes, something called cryoglobulinemia, arthritis, renal disease. And these people may have very early stage liver disease, and they need to be treated.
Right. So we just have a few seconds here, but Jonathan, as you see more and more people in your outreach work as a testing counselor, how tough is it to link those people to treatment?
It's nearly impossible. I'll just say very briefly, a lot of the people that I come across, it's what I refer to as a sort of a window of willingness that they may have. And this state does very, very well with HIV linkage to care and services provided. But right now, when I test somebody who's not even on the grid or their health insurance is very minimal, there's nothing I can refer them to. And that window might disappear, and it may never come back, their window of willingness to get into care.
Okay, we're going to have to leave it there for now. I'd like to thank Dr. Thomas Seepy and Jonathan Goyer for being up here. We're going to take a quick break.